Hello to everyone. I'm Eyal Steyer. I'm a pediatric hepatologist from Shaare Zedek Medical Center in Jerusalem, Israel. And it's a pleasure being here today, and I appreciate the opportunity that the ELPA, the European Liver Patients Association, gave me to talk to you today about rare liver disease in children. I think it's very important for both of you, we as a physician and you as parents, to have knowledge about your child's disease, and I hope this will help. So this is the outline of my talk. My previous talk was about liver diseases in infants. So I talked about one liver enzyme. So I refer you to the previous talk to hear a little bit about liver enzymes in children and in general. I will not talk about it this time. I will do talk about autoimmune hepatitis, PSC, Wilson's disease. So if a child has elevated liver enzymes, what does it mean? So not always severe disease. Sometimes it's normal variation of enzymes, and usually we do some investigation and it turns up normal, and we just leave it at that. Sometimes it's idiopathic, it's transient, it increases, it decreases, and everything is okay. We see a lot, unfortunately, fatty liver or NASH, non-alcoholic steatohepatitis, which is getting to be very common. I wish I could say that it is a rare disease, but it's not. It's very common in children now. I will not talk about it today. It could be elevation from viruses, various viruses, either hepatic viruses like hepatitis B, A, or C, or other viruses. Any virus can cause elevated liver enzymes, EBV, CMV, or others. It can be genetic disorders. So these are rare diseases. Wilson's, alpha-1 antitrypsin deficiency, autoimmune hepatitis. It can be medications. Always when we see a child with elevated liver enzyme, we need to assess whether it takes any drugs, medication, or even vitamins. Any of them can cause elevated liver enzymes. It can be bowel stones or cholelithiasis, primary sclerosing cholangitis, which I'll talk about, idiopathic cirrhosis. Sometimes we don't know the cause it causes cirrhosis, but often this is missed diagnosis that was done very many years ago. Or it can be non-hepatic causes. I will talk about it in a minute. So today I'm going to talk about Wilson's disease, autoimmune hepatitis, and primary sclerosing cholangitis. What is the non-liver causes related to transaminases, elevation of transaminases? So any muscle disease can cause, heart disease can cause, but usually these kids are sick, so this is a no-brainer. But celiac disease, or inability, the gluten sensitivity can cause elevated liver enzymes. This is very important to know, that celiac disease can cause a liver disease. So I would like to start with autoimmune hepatitis. This is a rare disease, although any hepatologist sees it a lot. Its incidence is around 2 to 10,000 people. We see it more in females than in males. The peak incidence in childhood is prepubertal girls. Mean age is about 6 to 10 years, and it's associated with other autoimmune diseases. I talked about celiac disease. It can be with that or any other autoimmune disease. It can present in various forms. In most people, it's incidental. You take blood tests for other reasons, and suddenly you see elevated liver enzymes. Sometimes it's insidious. You can just, the child does not feel too good, is tired, and then they go to the doctor and assess for, you do blood checks, and then you find elevated liver enzymes and autoimmune hepatitis. It can be acute presentation, like the child will have jaundice, will be yellow and feels well, pale stools and dark urine, and tests will show that he has autoimmune. The further stage is fulminant hepatic failure, which means that the liver actually stopped working very fast. And it can also present as cirrhosis and portal hypertension. This is usually in cases which are long-standing autoimmune hepatitis, which goes untreated. The incidence of autoimmune hepatitis and overall all autoimmune diseases rise in the last few decades. So any autoimmune disease increases for some reason. There are very theories, but the matter of fact is it increases. There's two peaks in life that you see more autoimmune. One is prepubertal or pubertal age, and the other one is a peak around the age of 60. There are many causes and many thoughts about what causes autoimmune hepatitis. There's some genetic predisposition, some potential triggers, just like viruses. So if we see that the child has CMV or EBV with elevated liver enzymes, and the liver enzymes do not get better as the time goes by, then we should suspect autoimmune hepatitis. And sometimes there's some imbalance which is not clear within the immune system. So any of these diseases or together causes autoimmune hepatitis. So this is just a diagram of how complex is the diseases and the pathogenesis of diseases. I will not talk about it today. So there's two types of autoimmune hepatitis. Type 1, which is ANA positive, which is a marker that your physician will send a blood test, and if ANA is positive and anti-smooth muscle is positive, then it's regarded as type 1 autoimmune hepatitis. Type 2 autoimmune hepatitis is with anti-liver macrosomal antibody positive and maybe anti-titrazole type 1 antibody. And another type is B in both types in anti-soluble liver antigen, SLA. The type 1 is seen in older kids, and it has better prognosis, and it reacts better to treatment, and usually it's less severe disease. Type 2 we mostly see in younger kids and babies, and it can present as acute liver failure, and it responds less to therapy. So how to make the diagnosis of autoimmune hepatitis? You mostly do blood tests, as I just talked about, and if you had a high suspicion for autoimmune hepatitis, then you do liver biopsy. You have very distinct features of in the liver biopsy, but not always it's very clear. You may see interface hepatitis, plasma cells. Very often you can say that it diagnoses it's compatible with autoimmune, but sometimes it's hard to actually say that. So what is the treatment? The mainstay of the treatment is steroids and immunoazothioprine. In acute liver failure, sometimes you don't have a choice other than liver transplant. So it's very important to diagnose the patient or the child early, and maybe to prevent liver transplant, although not always you can prevent liver transplant. So the treatment is steroids and azathioprine, but sometimes the child would not get better with this treatment. And there are other measures of treatment like budesonide, mycophenolate, cyclosporine, or tacrolimus. Any of these treatment or medication will we have various experience with that, but usually these are the second line therapy in autoimmune hepatitis. So how long do we treat? We treat for at least two, most of us treat for 3 years. And when do we stop the medications? In children, we do another liver biopsy. In adults, not so much, but in children, we usually rather see that the liver is normal and there's no inflammation in the liver, because many times there's no correlation between the normal liver enzyme and lack of inflammation in the liver. So once we do liver biopsy and the liver does not show any autoimmune inflammation, autoimmune disease, then we can stop the medications. So the treatment, stopping the medication, we should do liver biopsy, not before we see that there's normal liver enzyme and normal liver markers for at least a year. What is the prognosis? So some of the children remain with treatment all their life. Some of them we can stop medication. The rates are variable. Some say 20%, some say more. That can be permanently stop treatment. Some, about 8%, will progress to end-stage liver disease, and at some stage will need liver transplantation. So this is about autoimmune hepatitis. So very similar to autoimmune hepatitis, there's another disease that's named cirrhotic cholangitis. Cirrhotic cholangitis is inflammation in the bile ducts. If autoimmune hepatitis is inflammation in the liver cells, cirrhotic cholangitis is inflammation in the bile ducts. And the bile ducts inflammation causes biliary damage, bile duct damage, and what is seen here is bleeding and strictures of the bile ducts. Cirrhotic cholangitis is quite rare in children, as all diseases I just talked about. Incidence is about 3 new cases per million children annually, and it's more common with children with inflammatory bowel disease. 10% of the children with UC, ulcerative colitis, will have also PSC. More common in children, we see what we call autoimmune cirrhotic cholangitis, which is unlike in adults, and unlike cirrhotic cholangitis, autoimmune cirrhotic cholangitis is a chronic inflammation of the bile ducts, but there's also inflammation in the liver itself. There's positive antibodies just like autoimmune hepatitis. There is interface hepatitis in the biopsy, and you can treat them just like autoimmune hepatitis. So we have a lot of knowledge from the adults about PSC, cirrhotic cholangitis, but we see more autoimmune cirrhotic cholangitis in children than in adults. There's less biliary strictures and complication in the bile ducts in children versus adults. So usually I tell my patients not to go to read on the internet, because most of the data and the papers you see in the internet is in adults, and children are doing much better than adults. There's less cholangiocarcinoma, which is it's a tumor in the bile ducts in children rather than adults. And the overall prognosis is better in children. So until recently, we relied a lot on studies on adults, and there's very small cases, series, and single centers studies, and we didn't have much to tell the families about PSC. But just several years ago, a group from Utah University in the US has formed the Pediatric PSC Consortium, and which take part like 60 nations, 50 centers around the world, and this actually made a very significant progress in the knowledge of PSC in children. We have many articles and manuscripts from this consortium that helps us understand more about PSC in children as opposed to PSC in adults. We know now that the disease progresses slowly throughout time, and there's complication of portal hypertension, about 5% in diagnosis, and as a year goes by, there's 40% after 10 years of disease, but only 30% of children will need liver transplant after 10 years of disease. Many of us used to treat PSC with ursodiol. The studies of the consortium showed that there is no effect of ursodiol on PSC, as just like in adults. And we talked about gamma GT. So gamma GT is an enzyme that is within the bile ducts, and once the bile ducts are injured, then you can see gamma GT high in the bloodstream. So gamma GT is a good marker for good prognosis in these children. If the gamma GT goes down after diagnosis, the first year after diagnosis, then we can say that the outcome is favorable and less likelihood that the child will undergo liver transplantation. Other than that, we still don't have any good treatment for PSC, both in adults and children. There are many studies in adults, there's some studies in children. There's few drugs, just like IBAT inhibitor. I can show you here that Albireo does some studies in adults and children with PSC, as well as Mirum that does some studies in PSC. So, and there's other studies in adults that are ongoing that are hopefully will lead to some treatment in PSC, both in children and in adults. So this is about PSC. The next disease I would like to talk about is Wilson's disease. Wilson's disease is genetic disease. It affects about 1 to 4 to 10,000 people around the world, of course, depending on where about in the world. It actually causes a lack of excretion of copper from the liver. Once the copper accumulates in the liver and in other organs, it can cause liver damage and other end organ targets. It's a mutation in ATP B7 gene, and there are many mutations that are already known. And if you don't treat the disease, it may be fatal. So before the age of 2 or 3, we don't usually think about Wilson's disease because the accumulation is not fast. But if you have a child above the age of 3 years old, then with elevated liver enzymes, we should think about Wilson's disease. So Wilson's disease can cause various symptoms or problems. Most of all, it can damage the liver, can cause cirrhosis, hepatitis, and even fulminant hepatic failure. Just like autoimmune hepatitis, this also can present as acute liver failure. It can cause brain damage. This is usually later in life, so it's rare for us to see kids with some central nervous system damage. Usually, we see it around the age of starting at the age of teenage, 13, 14, 16. But adults are more seen with central nervous system manifestation. You can see Kaiser-Fleischer ring in the eye, and more rarely there's some bone damage, hemolysis, cardiac damage, and brain damage. So Wilson's disease is rare disease, and it can cause multiple damage in various organs. As in autoimmune hepatitis, just until recently, we relied on papers from adults, but now 2 years ago or 3 years ago, There's a position paper from the European Society of Pediatric Gastroenterology and Nutrition that summarizes the position about children with Wilson's disease. This helped us a lot in taking care of children with Wilson's disease. How do we make the diagnosis? Diagnosis is made by blood tests and urine tests. We do we take seroplasmin, which is a mark a protein that absorbs or takes upon the copper. This is low. It is low in Wilson's disease. We also do urine tests, 24 hours urine tests, to see how much copper is within the urine. So this is the first step. If you have elevated liver enzymes and it's prolonged, then you assess for Wilson's disease. If you suspect Wilson's disease, the next step is genetic testing. But in some countries there's not genetic testing available, then we do liver biopsy and assess for the amount of copper in the liver. So once we make the diagnosis, we have to treat. So the initial treatment is you have to have diet with low copper, which is not very easy to do. There's high copper content in very good things like nuts and chocolate. So it's not easy to do a low copper diet. The initial treatment, if the patient is stable, if the child is stable without significant liver disease, then we give zinc. Zinc actually precludes the copper to get absorbed in the intestine and therefore lowers the amount of copper in the body. So this is a good treatment, and if the child is stable and not with significant liver disease, this is the way to start. If there's more progressed disease, then we give chelation treatment, either with deep penicillamine or with trientine, which what this medication does is takes out the copper from the liver and from the body and secrete it through the urine outside the body. So this actually is a good treatment, but with some side effects that if we can, we start with zinc, and if there's progression of the disease, we give penicillamine or trientine. Sometimes we don't have a choice, and if it's the presentation is acute liver failure, then we need to. The child has to have liver transplantation. But there are some future disease treatment like cell therapy or gene therapy. Since it's a single mutation and known mutation in known gene, then gene therapy is a good option for diseases, and there are some studies that are trying to give gene therapy to Wilson's disease. So if the disease progresses, we need to take care of the secondary side effects of the disease, like portal hypertension. We need to look for hepatic cancer, treat the neurological symptoms if there are, and sometimes even psychiatric symptoms. So this is about Wilson's disease. So in summary, most rare liver disease in childhood are treatable. So it's very important, if you have a child with elevated liver enzymes, it's important to make the diagnosis fast and treat as fast as possible. Elevated liver enzymes should have prompt investigation, and early diagnosis can prevent long-term complication in these kids. Thank you for your attention, and I'll be happy to answer any question if you have. And again, thank you for the European Liver Patient Association for having me talk today about rare liver disease, both in infants and children. Thank you and have a great day.